Welcome back, everyone, to the second ASEM Forum on the Human Rights of Older Persons. We are ready to begin our afternoon with our first session entitled Mental Emotional Health of Older Persons, Current Status and Response. The first session will be moderated by Professor Kim Giyeon at Chung-Ang University. Let us welcome her to the stage with a big round of applause.
Thank you for the introduction, and I'd like to thank ASEM Global Aging Center for organizing this important forum. Hello, everyone. Again, I'm Giyeon Kim, professor in the Department of Psychology at Chung-Ang University, Seoul, Korea. I'm the moderator of this session, and I'm very honored today to moderate this first session focusing on mental and emotional health of older persons. It's an absolute pleasure. Welcome to all of you in the room and presenters joining us online, and also our audience joining us online. So we have three presenters for the first session. The first session is entitled The Mental and Emotional Health of Older Persons, Current Status and Responses. So each presenter will share their thoughts and also the current issues with mental health and emotional health of older persons in each country and all that. So in this session, expert panels, three panels, will address various issues related to mental and emotional health, including depression, suicide, and loneliness. Given that we have two and a half hours and three presenters, presenters can take about like 30 minutes or so, and then we can, at the end of the presentations of three presenters, we can have some discussions, and also we can take questions and all that. So that's how we will do. So with that, so the first presenter is Dr. Debanjan Banerjee. And so he is in the Department of Psychiatry at the National Institute of Mental Health and Neurosciences in Bengaluru, India. So his talk title is titled Right and Person-Centered Old Age Mental Health Care, Lessons Learned from COVID-19. So without any further ado, let's welcome the first presenter, Dr. Debanjan Banerjee. Dr. Banerjee.
디반잔 바너지 박사님 모셔보도록 하겠습니다.
Yeah, hi. I hope I'm audible.
여러분 안녕하십니까?
Dr. Banerjee.
네, 바너지 박사님.
Could you please share your PowerPoint slides?
공유해 주시면
Yes.
될 것 같습니다.
Yeah.
Thank you.
네, 감사합니다.
Yeah. I think the screen is visible and the slides are moving.
네, 지금 잘 보이시죠?
Can I have a confirmation on that, please?
Yes, it is moving and we can see it very clearly.
Yeah. Thank
잘
you. Thank you.
보입니다.
So, warm welcome and greetings from India.
인도에서
It's,
인사 말씀
Always
드립니다.
a pleasure, to be amidst a discussion on human rights and mental health of older persons.
인권과
Thank you, Professor Kim, for the kind introduction, and I also thank all my co-panelists and
소개해
co-speakers
주신
today.
좌장 김기현
Please
교수님께
feel free to
감사합니다.
interrupt me at any point of time if the slides are not moving or you are not able to hear me.
잘 움직이지
And
않고
I sincerely thank the AGAC Forum for having me here.
이번
It's an honor and
포럼에 저를 초청해
privilege to be
주셔서
here amongst all
정말
of you.
감사하다는 말씀을
So
시작하고자
I should
합니다.
also speak on behalf of the International Psychogeriatric Association, with which I closely work with. And I convey my regards to all of you from the IPA. And again, it's always great to have a discussion related to human rights, especially in the post-COVID time. So what I'll be going to do in the next 20 minutes or so is kind of take you through the different aspects of mental health care in older persons, especially in the post-pandemic times, and especially with regards to how COVID has kind of changed and made us rethink about human rights in this particular age group. There is a slight disturbance in my screen. I believe I'm still audible, right?
Mm-hmm. Yes, we can hear you pretty well.
Yes, perfect. Thank you. Thank you. So firstly, I congratulate your forum for selecting such a pertinent area because, just last year, the theme of World Mental Health Day was mental health inequalities or mental health in an unequal world. And this year, it's a global priority. So this cannot be a more relevant time to discuss a rights-based psychological and emotional health care for older persons. And, it's always been that when we talk about mental health as a psychiatrist, as a geriatric psychiatrist who work with older persons, especially when I talk about my country or in South Asia, there is always a predominant focus on symptoms, on symptom recovery, on reduction of the psychological burden of symptoms. But somewhere down the line, when we talk about this, I think the rights-based aspect, the person-centric care, the narratives of the person who is suffering from the illness as well as their family members, especially in illnesses like dementia, are really, really neglected. And this happens especially because, we have a huge population and to be honest, India is one of the fastest growing countries. We are having a rapid demographic transition, and so is for the entire world. So as we really go to a very, very high projected score of, population of senior citizens, it becomes extremely important to think and rethink today's topic. I just have a small request to moderator Professor Kim. It's actually morning time for us here, so maybe I kind of have to finish my presentation and then stay for a while and leave. So I'll be really happy if I can take the questions at the end of my presentation, and I'll be happy to answer them. So to move ahead with the presentation, this is something which has always, been one of my favorite quotes or lines by Russell. Age is like a ladder which takes you high. It brings experience, it brings wisdom, it brings a lot of positive things, but it also brings risks. And if we are sensitive about that risks as physicians, as individuals working in mental health, as individuals working in area of health related to older persons, and especially as a community, I think it's very important that we safeguard their rights, especially at one time when they are very, very vulnerable. So to start off with this premise, as I was discussing with you, by 2050, based on the United Nations projection, number of individuals above 60 years are going to make up nearly 20% of the population. And just imagine in sheer terms of numbers, what that's going to get us to. Now, this demographic transition, this change in the population dividend, mostly affects lower and middle income countries. Rough statistics, 1 out of every 8 people across the world are 60 years or more. And what the pandemic, it's still going on for last 2 years with all this lockdown and consequent changes, what it has really made us feel is that you know, it's very important to reconsider and rethink how are we going to shape mental health services and policies for this age group, because the problems, the vulnerabilities, the inequalities, and the human rights crisis are forever increasing. And age is not a constant. We all will be aging. In fact, today I'm talking here, 30 years, 40 years down the line, I'll be in the same age group that I am talking about today. So if we have to make the world a place which is suitable and age-friendly, then we have to start working now, all of us. And only then will this dialogue that we are discussing today be relevant in the future times. Now, if we talk about rights, the Universal Declaration of Human Rights, it clearly mentions that all human beings are born free and equal in dignity and rights. This is irrespective of age, culture, creed, socio-economic status. So when we talk about human rights, there are no age bar. We cannot deny any age group of any particular rights, human rights. Now, the issue is that, a lot of these are considered to be implied. And as mental health professional working in this area, what I sincerely feel, I really welcome all your thoughts on this, is that because this is very much implied, we do not really take an extra step or a measure to protect these when these are more vulnerable. We talk about children, we talk about women, we talk about older people, we talk about the gender and sexual minorities. But the problem is, there is a very covert ageism that is present in all of us, all throughout. And when a person ages, when a person is probably not cognitively or psychologically capable enough to protect his or her rights, it actually is the onus of the society and the policy makers to protect them. Of course, taking into account their considerations. Now that is sometimes missing because we often tend to think that with age, it is natural but to sacrifice some of these basic factors of dignity. That is where the global problem lies. Now, what I'm also going to do today is, because I speak from India, it's always great to talk about the regional factors. So I'll be talking about South Asia in general, the Indian subcontinent, and few other countries. So when this whole thing before COVID started, there were a lot of discussions, in different policy papers related to how we can rethink or remodel the older adults' mental health care in South Asia. Because one, it's rapidly aging. Two, we really lack facilities and lack guidelines to provide age-appropriate, rights-based mental health care for them. And I think it's very important to learn. So today, when I speak here, I think I would also like to take back your ideas, the ideas and discussion from the other panelists here today, and then try to incorporate them in different policies and services that we have, because discussions like this, multidisciplinary discussions like this, really bring on a mutual exchange of ideas to help those who need that. So, this was one of the documents that we published as a part of the World Federation for Mental Health. This was released last year, one of the regional position statements, and this was the position statement from Asia Pacific, and led by Dr. Roy Braham from India. We kind of tried to put together different aspects of how different vulnerable populations do face this mental health inequity and inequality. Now, when we talk about mental health care in the Asia Pacific region, and I'll come to the older adults part in a little bit, we talk about all these factors. We talk about the differences in politics, the changing of demographics and gender equality, mental health policies, the immense amount of climate changes, employment conditions, socio-economic disparities, differences in social security policies, human rights crisis, stigma related to mental health and vulnerable population, change in the family structure, which becomes very important when we talk about older people, because COVID has actually shown us a lot of separation, change in family dynamics, change in family structures. Nuclear families kind of tend to become more segregated. Income inequalities, climatic changes, the influence of the pandemic, and finally, the health-related behaviors and preparedness, disaster preparedness, as we talk about it. So I'm sure that these are the factors which probably influence mental health in every single country. But I just wanted to bring this out to kind of show that how unique each region is. And hence, an inter-regional dialogue or collaboration like this becomes very important for safeguarding mental health. Now, as I mentioned already, what are the specific mental health challenges related to aging? I already emphasized on a rapidly aging population, the ever-increasing trend of dementia, 1 million nearly each year, according to the WHO estimates. Limited primary mental health care resources, at least at our place, we are heavily biased towards tertiary care. So if you go to the rural areas, if you actually go to community health services, they may not be well equipped with dealing with mental health care challenges. There are the issues of migration, homelessness, unemployment, and finally, and most importantly, ageism and elder abuse, which I'm going to come in a little while. This was the largest mental health survey conducted in India. A little bit older though, 2015-16 by the National Institute of Mental Health and Neurosciences, of which I was a part of for around a decade. So this is one of the largest, in fact, the largest survey in India, one of the largest in any countries. And if you actually look at the data, it is alarming. 1 in 3 individuals over 60 years have some neuropsychiatric condition which may be detected or not. The other important factor is treatment gap. So out of every 100 individuals who have mental health condition, only 15 do receive some form of treatment. Considering our population, just imagine the burden it can create on our mental health services. I started off by mentioning that we cannot just look at symptom recovery. So it's very important to look at the social determinants. Now, we know that health is a composite, multidimensional, intersectional structure. When we talk about aging, when we talk about healthy aging, we also need to keep in mind the factors of digital literacy, social security, justice system, especially with respect to human rights, a spiritual dimension, which may be important for many of them, discrimination, health inequalities, and finally, the factor of abandonment and loneliness. Without these factors, when we talk about the biopsychosocial model, without these factors, it is literally impossible to conceptualize mental health services when a person ages. And this is probably one of the most appropriate forums where we can discuss these factors in detail. Let's see what the pandemic has done. We are all aware by now that older people were more vulnerable both physically, medically, and psychologically to COVID. Nevertheless, besides the biological changes, there were a lot of other factors that came into being. People getting stranded, people getting deprived of basic amenities like food. Many people may not be having their domestic help. The fear of stigma, not letting older people to go out. Someone might, an older lady may just have 15-20 minutes walk in the afternoon as the only recreation that she had, but that was kind of taken away. So it was removal of autonomy and independence. A rapid burst of misinformation. Many people, many senior citizens lost their loved ones, their children, their spouses, people who are younger to them. Existential issues come into being that, Lord came to us, we were operating an elder helpline. And so many calls came to us telling that, doctor, why not me? Why did my son pass away? I rather wished it was me, because anyway, I'm 70, 75 years. So there was a long-standing grief, a chronic trauma, and what COVID really, really showed us. In fact, whenever I am in a talk, I always tell that it's very unfortunate that we needed a pandemic to serve as an eye-opener, is that how much ageism and how much of stigma kind of really persists among us. So, it's very unfortunate, but in different communities, and I'm sure you can, again, your experience will be invaluable. I can speak from my end. In all the countries that we collaborated with, when we spoke about this care, most of my colleagues did mention that it was so much of a crisis in this entire 2 years that people literally considered older people as disposable. Now, probably it was the crisis reaction, but there are certain vulnerable age groups who have suffered the maximum brunt of this pandemic. And I should be very clear about this, and I should actually appeal to all my colleagues and the audience present here that this is just the start. Probably now, as years go by, this is only going to be a cascading exponential effect of the pandemic that we see on the senior citizens. So if we have to keep our antenna open, we have to do it now, because more and more people will be coming with the problems. Help Age India brought about this document, which was immensely important and touching. We showed that there was a degree of, a lot of unvaccinated individuals, increase in elder abuse, financial insecurity, misinformation with related to vaccines, especially those who are in nursing homes, assisted living facilities, those who are institutionalized. And finally, many felt that their personal dignity was compromised. These were our work during the COVID period, when we spoke about how, the human rights crisis is kind of predominating all over during COVID. You are just free to check out these papers. They are all freely accessible on the net. We did try to provide certain advocacy measures, especially to care for older people in general during the pandemic. Also those who are living with dementia and their caregivers, because they're increasingly vulnerable. And most importantly, I think we need to understand that just medical care is not enough. Improving healthcare access, improving their literacy, trying to talk to them and understand where the problem lies. Many people called us simply asking that my children are there in a different country. I don't know how to operate WhatsApp, Google Meet, Zoom. I can't even see their face. I just feel that, something will happen to me and they will never be able to reach out. Now, this is categorically not any ICD DSM diagnosis, but this is far more than that. So as physicians, I think it's important that we start thinking a little bit out of the box, beyond the categorical diagnosis system, and try to think that each individual has got affected in a unique fashion during this pandemic. And mental health can have many, many shades. Just in the same lines, we spoke about this in another publication of us, and many of my esteemed colleagues from the World Psychiatric Association, the IPA, were there. In this document, we specifically mentioned about the factors which lead to health inequality. And this is the core of my presentation today, where human rights and mental health intersect. So loneliness, neglect, ageism, discrimination, reduced access, institutionalization, elder abuse, prone to misinformation, especially individuals who have cognitive problems, who have hearing loss, visual problems, frailty, have restricted mobility, who are staying in nursing homes and assisted living facilities, they are probably more and more impacted. And one important thing which envisages this whole thing is that we do not have, and mostly, I mean, I'm not aware of every single country's policy, but overall, internationally, it's very difficult to have standard guidelines which protect the rights of older people. I'll actually be coming to this in the end of my presentation, how we have been campaigning for a specific convention, a United Nations Convention for Rights of Older People, but yet it's such a big struggle because many people do feel that it is not necessary. We also did recommend certain strategies to restore health equality and social inclusion for older people, and most of them they include healthy aging, including their narratives in the society, promoting community participation, developing specialist and dedicated services, improving awareness, having affordable dementia care, having both preventive, curative, and rehabilitative services, more and more promoting financial independence and social security of older people, and having a comprehensive plan, not just mental health or physical, but also occupational, also, home visits, trying to have a home environment set up, trying to kind of rebuild their families, and finally, having aging research. And that can be collaborative, inter-country, inter-regional. This was the paper that I was talking about, and this is pretty much the same discussion that we had a few minutes back. I just like to stress on the fact here that if we have to build services for them, it has to start right from an individual awareness, right to the point where the community is involved. And without mobilizing the policymakers, the local leaders, the government, it is impossible. So each one of us, and this will be my message today, to appeal to each one of you to serve as a messenger for this cause, so that you can mobilize, you can educate, you can make every person around you aware of the need to fight for the rights of older people. And this is often neglected. We focus a lot on symptoms, but supervision, the vulnerable groups, marginalization, cognitive deficits are extremely neglected when we talk about general health care. In fact, sometimes they are not even screened. So we keep in mind this increased risk of abuse and discrimination. And when we talk about elder abuse, it's a growing social evil. It is not just limited to physical abuse. It can be psychological, sexual, neglect, abandonment, medication abuse, chemical restraints, financial exploitation. And data is extremely restricted. In fact, back on June 15th, when we were having a discussion for this World Elder Abuse Awareness Day, we actually realized that how limited data is from lower and middle income countries, because many of them do not report because of the fear of legal hassles, because people may not believe them. And even though when we get sometime calls, the next time we call them back, they're invisible. I really like to stress on the fact that elder abuse does have a particular definition, and it's not an abstract term. So it's a single or repeated act or lack of appropriate action where there is a relationship, expectation of trust. Most perpetrators are actually individuals who know them, and the community prevalence is as high as 15.7%. And all across, data shows that because of closed doors, social distancing, restricted living, elder abuse has actually gained a tremendous impetus during this COVID-19 pandemic, which can have very serious adverse consequences. And abuse is not just a physical harm. It can cause long-lasting trauma, complex PTSD. It comes out of ageism. It comes out of a perennial, pervasive fear of aging, equating age with something which is dark, black, ugly. And usually, it is not having a separate legal status. It doesn't have guideline, policy, a particular aspect of punishment. And because of this ambiguity, elder abuse continues in societies today, undetected, neglected. There are different factors, starting right from individual to community. Few are, of course, shared living, dependency, cognitive deficits, substance abuse in the caregiver, poor intergenerational bonds. And in fact, this year, the International Youth Day, the theme was on building intergenerational bonds, which was fantastic, because I'm sure many in the audience will be a younger population. And if we can sensitize them then a community, a resilient community will form which can fight elder abuse and protect the rights. And finally, isolation is a major, major risk factor. I'd really request everyone to go through this special issue of American Journal of Geriatric Psychiatry, which was released last year, which specifically focuses on human rights. And again, we were fortunate to be a part of one of the policy articles. What you see on the screen is an intersection between how ageism and discrimination intersects with dignity and intersects leads to human rights crisis. So the inequality, the ingrained stigma and ageism that is there in the society, added by the frailty of older population, actually leads to compromised dignity, which finally leads to human rights crisis. And the box in the bottom is most important. We do lack an age-based standard, be it a national or international standard of rights, which we can refer to protect these rights. This was released by World Health Organization fairly recently, and I couldn't believe my eyes when I saw that 1 in 2 people worldwide are ageist against older people. We all share that almost. So how we think, how we feel, and how we act. And imagine 50% of the world's population, which is no way a matter of joke. And this ageism is not only limited to older people, it's also towards younger people. Any form of ageism is harmful. But why especially in older age? Because the vulnerabilities increase and it can affect their physical health, their literacy, their mobility, their mental health, and it can even affect cognitive decline, because we do know that isolation is a major risk factor for cognitive deficits. And when we talk about dignity, we talk about consent, autonomy, respect, and equality. All of us would like to be treated well, and we like to feel good about ourselves. So what we want now doesn't change when we turn above 60 years. And dignity becomes extremely important in mental health care. And that's why, again, today's discussion becomes extremely important. This is one of our works where we speak about how dignity can actually be focused on and how is it compromised. So these are the same factors, in institutions, when we do not have appropriate access to healthcare, when you are denied of a particular aspect because you are aged, when people do not understand that you have psychological and sexual needs and they are deprived, especially you are not given privacy, confidentiality when you are aging. That is when dignity gets compromised. I will not read through these. These are the human rights in older persons, which have been documented in different documents, including that of the United Nations. More importantly, I would just like to focus on the first line. They have the right of enjoyment of highest attainable standards of affordable global health and the respect of specific needs in different stages of life, which obviously include older age, and safeguarding against any violence and undue influence and abuse. If we have this in mind, we can actually build mental health services based on these principles. I should also mention specifically about people living with dementia. There have been several literature which came up as to why dignity in dementia gets compromised, because person may not be able to understand what's good or bad for them. They may have behavioral and psychological symptoms, increased risk of institutionalization, chemical restraints, abuse, distance from the family. There are issues related to end of life care, and a lot people have actually declined. I'm sure many of you who work have actually seen a rapid decline in cognitive status, especially due to lack of social stimulation, abuse, and restriction of movement, restriction of increase in frailty during this pandemic. And why are these important? Because autonomy is compromised. There is problem with family, dependence, caregivers get burnt out because many times they couldn't get access to health care. Many individuals with dementia will not be amenable for an online consultation, telemedicine, lack of awareness. And finally, when individuals have started having behavioral symptoms which have gone out of control, they needed to be institutionalized. As I come to the end of my presentation, I'd just like to focus on why have we been fighting for a United Nations Convention. Just like we have the United Nations Convention of Rights for People with Disabilities, the UNCRPD, similarly, why can't we have an international binding for older persons? It can serve as a legal anchor for all nations to abide by. It can have a clear, comprehensive, international, legally binding framework. All of us working in this area can actually support it and make sure that it eventually turns into a benchmark that we can refer to. And that can be built into different national guidelines so that we have some policy in place. And these discussions that we are having today become more and more relevant. Recently, the IPA, the Global Association for Rights of Older People, GARUP, they had come together for a global rally to support this United Nations Convention. And even though there have been multiple obstructions in the way, I'm sure that with all of your support and with forums like AGAC, we'll be able to go ahead and make this into a reality. So what do we have in line ahead of us? We need a person-centered dementia care. We need regional dialogue and collaborations like this. We need more of longitudinal aging studies. COVID has taught us a lot. How we want to take it, whether we want for another pandemic to change, that depends on us. And more importantly, we cannot focus on the well-being of older persons without including their voices. I always remember speaking to my grandparents and they telling that, probably we have seen life more than you, but you see life through our eyes. And that's what makes the difference. We need to think like them. We don't need to wait till we age 60, 65 for somebody else to make the decisions for us. Lastly, today we stand in the United Nations Decade of Healthy Aging, 2020 to 2030. So this discussion becomes all the more relevant, and let's make a difference if we really want to. I should invite all of you to the upcoming Older Adult Mental Health Awareness Week. This is the website. Please feel free to refer for same. It starts with 1st October with the International Day for Older Persons and ends on 10th October with the World Mental Health Day. Finally, I'd like to extend my thanks once again to the forum for having me here, to the audience for their patient listening. Let's make the world age-friendly as how we want when we age one day. And here lies the difference. Thank you once again.
Thank you, Dr. Banerjee. I really appreciate that you shared very in-depth discussion on human rights of older persons and mental health issues. Very much enjoyed your talk. And before we move on to the second presenter, Professor Ha, Dr. Banerjee gave us some special requests. So given Dr. Banerjee's special request, we will take a few questions for Dr. Banerjee before we move to the next presenter, given that he has to move a little bit earlier. So we received a question or two for you, Dr. Banerjee. So you can probably answer that right now. And then if we have some more questions from the audience or the audience online, then you can probably just share your email address. They can probably directly ask you. Would that be fine with you?
Yes, thank you so much for accommodating the request. I mean, I actually would have loved to stay throughout the session, but it's kind of a little bit odd time for us. But, I have actually shared my email ID at the last slide, and I really would, it would be my pleasure to answer any of your questions if you can just direct it to me via the mail ID throughout the presentation or even any time later. Thank you.
Okay, that sounds very good. So we have a question from the, we received the question. So the question is, around the world, many older people with mental health challenges are deprived of their right to be treated as valued individuals. As you mentioned, dignity is considered a cornerstone of mental health care because people affected by mental disorders are often subjected to discrimination. Human rights principles are not always honored in mental health care, and essential services are not equally distributed. So this might be due in part to the unclear way we conceptualize the term dignity, as doing so may cause us to overlook this issue. So first, I'd like to ask, at the facility level, to determine how dignity should be conceptualized. That's the first question. And the second, I'd like to understand how we can assess and improve dignity at the mental health care facility level.
Thank you so much, Professor Kim, and thanks for the question. I think it is a very relevant question at this forum. Firstly, the problem with this term dignity is that it has been conceptualized in very different ways. And whenever I do discuss about this in any of the conferences or forums, it tends to be very abstract. So many people actually ask me that, Doc, you were talking about dignity, but how do we really find out, or is there a scale to assess it, or how do I really assess it clinically? Now, I think the answer lies in the fact that there have been different researches related to this, how to conceptualize and how to understand dignity. But how I look at it is, let's look at ourselves. If I, let's say in this forum, each of us would want broadly three things. One, that I feel good about myself. I feel good about the person, how people interact with me, and I feel good about the situations around me. Now, by feeling good, I do not mean that it has to be a persistent feeling, but I need to be felt listened to. I need to feel somewhere important, wanted. Now, it may be a very psychologically abstract concept, but broadly, dignity has two dimensions: self-dignity and perceived dignity. Self-dignity is how one perceives or thinks about themselves. Perceived dignity is how that comes from others. Of course, it is related a little bit to the theory of mind that we discuss in mental health. But there is no hard and fast rule or scale to assess it. It's like assessing pain, or it's like assessing an experience. So it's very qualitative. I think if a person does feel discriminated, I did show the components, how dignity is compromised. So if a person feels stigmatized, discriminated, neglected, abandoned, not listened to, not heard, the person will actually tell you. So I think as clinicians or as workers in this field, we should make it a point to spend at least some time with each individual coming to our clinic with their problems, irrespective of the type of problem, to just talk to them and make sure how they feel or think about themselves and about how others treat them. I think here is where the key difference lies. It may be a very busy OPD, but still that time matters. To answer the second part of your question as to how we can improve it, I think the key is sensitizing ourselves and others. I'll be extremely glad that even if a few persons in the audience kind of take this message back and start implementing it as a messenger in their day-to-day services, it's going to be wonderful. Because, we only probably understand dignity when it comes to us, but probably discussing with patients, discussing with older persons, it's a very important component to consider their autonomy. As I mentioned, it's commonly rubricated as CARE, C-A-R-E, where C stands for consent, A stands for autonomy, R stands for respect, and E stands for equality. And let me once again reiterate this: it is not an abstract term. Dignity needs to be maintained on an individual discussion dignity also needs to be maintained in institutions, in nursing homes. Let me give you one very small example before I finish. Let's say there is an old age home or there is a senior care facility where there are older people residing. You know, it's very common for people to address them by their first name or address them by their pronouns or just refer to them as he or she. Sometimes it is very common to see that once a healthcare worker enters their room and comes out, the door is left open, or sometimes they will just barge in without knocking, just assuming that anyway this person probably will not be able to respond, so what is the need to really knock and take his or her permission? Now that is compromised dignity. Neglecting sexual rights, reproductive rights in older individuals is compromised dignity. Neglecting their mobility and not respecting their independence is compromised dignity. So each of these acts makes a difference. And if as individuals we are sensitive to their needs as much as we are sensitive to us, I think we'll be able to make a difference in clinical care.
Thank you, Dr. Banerjee. I'm sure your answers to the questions are very helpful to the audience to understand dignity at the facility level and other issues. So thank you very much for your excellent answers. So with that, thank you, Dr. Banerjee, for the wonderful presentation and wonderful answers. So now let's move to the second presenter. So second presenter is Professor Jung-Hwa Ha. So her presentation title is Mental Health of Older Adults in Korea, Current Status and Policy Responses. Professor Ha is professor in the Department of Social Welfare at Seoul National University, Seoul, Korea. So let's welcome the second presenter, Professor Jung-Hwa Ha.
Hello. Hello, everyone. Thank you, Dr. Kim, for introduction, and thank you, ASEM Global Center, for inviting me and having this opportunity to present to you. I'm very honored and pleased to be here today. So today I am going to talk about mental health of older adults in Korea. I was asked to give a very general overview of mental health issues in older adults in Korea. So what I'm going to do is, so first, provide you a brief overview of current status of Korean older adults mental health and introduce to you some policy responses to mental health issues in Korea. I was actually very impressed by the first presentation by Dr. Banerjee, and he talked a lot about ageism and discrimination against older adults, stigma and other issues. And those issues are very important in Korea as well, but in this presentation, I'll focus on more general issues and policy measures. So before I go on to what we are doing in Korea, I would like to visit World Health Organization's definition of mental health. It says on the World Health Organization website that mental health is a state of mental well-being that enables people to cope with the stresses of life, realize their abilities to learn well and work well, and contribute to their community. And mental health is more than the absence of mental disorders. So in this presentation as well, I would like to focus not only on the mental illnesses of older adults in Korea, but also general emotional well-being, as well as other mental states that affect their emotional and social well-being. So let's get to the current status of mental health among older adults. So in terms of general stress, the recent survey shows that the overall stress of life among older adults, among people who are age 65 and over are as shown in this slide. So about 6.2% feel that they're very stressed, and 36.6% tend to feel some stress, and 44.5% report that they tend not to feel stressed, and 12.8% say that they have no stress at all. So in total, about 40%, a little over 40%, say that they have some stress in their life. When we get to depressive symptoms, which are one of the most frequently used indicators of mental health in Korean surveys, we see that the level of depressive symptoms has been decreasing over time since 2014. So in the 2020 survey, we see that 13.5% reported 8 or more symptoms on the shortened geriatric depressive symptoms scale. However, we need to be cautious in interpreting these results as enhancement in mental health, because these are repeated cross-sectional data, and in the recent surveys, the new cohorts of older adults are added to the survey. So the new cohorts, especially the baby boomers, may have better health and mental health compared to previous cohorts of older adults. So we need to be careful about this trend. We find that depressive symptoms are higher among females than males, and those without a spouse than those with a spouse, and among those who are unemployed than among those who are employed. Also, more people show depressive symptoms in older age groups and among people with lower levels of education. In terms of clinical mental illness, we find that there's increasing number of older adults with mental health problems. So in panic disorder, sleep disorder, eating disorder, and depression, we find increases in the number of mentally ill patients. Of course, these are numbers, not percents. So over the last 10 years, the number of older people increased. So the number reflects that as well. But when I calculated the percent of those who have mental illnesses, the percent also slightly increased over time. Despite the increasing awareness of the importance of getting adequate treatment for mental health problems, Korean older adults are still reluctant to receive mental health services due to misperception and stigma attached to mental illness. So when we see older people who are depressed, they know they are depressed, but they don't want to go to see a doctor for that problem, even though older adults are very active in pursuing doctors or healthcare services for their physical problems. Also, mental health problems such as depression frequently get unnoticed by family members because older adults express them through somatic symptoms or physical symptoms. And this is somewhat problematic because depression especially is one of the most influential risk factors for suicide, and is also associated with higher risk of dementia. And when it comes to suicide, you probably, people who are here probably know that Korea has been always at the front in the highest suicide rate among OECD countries. So even though the rate itself is decreasing, Korea is still leading the suicide rate, both among everyone and among older adults. Also, this the red circle shows that 53 people out of 100,000 people committed suicide, according to 2019 data in WHO. Suicide rate is higher in old age group than in other age groups. So if you look at suicide rates of South Korea in 2020, we see that the rates are the lowest in the teens, and it's in the 20s. It ranges from 21.7% to 29.2% among 20s through 40s. And when we get to older adults, it becomes over 38%, and among the oldest old is over 60%. Some of the main reasons for considering suicide among older adults include health problems, economic difficulties, loneliness, death of family, conflict with family, and family care problems. And lastly, I'd like to talk about the problem of dementia in Korea. So as of 2021, the percent of people diagnosed with dementia among those aged 65 and over was 10.2%. And the number of people with dementia will grow with population aging. And there's a lot of burden to caring for people with dementia, and the economic burden is increasing with the growing number of dementia patients. The Korean government expects that the annual cost of dementia patients is about $16,849 annually per person. And in addition to economic burden, there's psychological and social burden of caring for people with dementia. The burden of dementia is not just a problem of more aged societies. The risk of dementia increases sharply with age, and populations in the less developed regions of the world are aging as well. And as you can see in this graph, we can see the number of people with dementia in low and middle income countries will be almost more than double than the number of people with dementia in the high income countries by year to 2050. And currently more than 55 million people live with dementia worldwide, and there are nearly 10 million new cases every year. So what are Korean government doing to address mental health issues in Korea? I'd like to introduce some policy measures that are being executed in Korea. And the first one is Mental Health Welfare Center. So there are several mental health institutions in Korea under the jurisdiction of the Ministry of Health and Welfare that include Mental Health Welfare Center, Addiction Management Integrated Support Center, Suicide Prevention Center, Mental Rehabilitation Facilities, Mental Care Facilities, and mental hospitals. And this Mental Health Welfare Center is more community-oriented center where people can get not only medical care but psychological counseling and other support. So this center was established in 2016 when Korean government developed a comprehensive mental health plan to enhance mental health across the life course. And this center plays an important role in providing integrated mental health services in the community. So the main goals of this center is to plan, establish, coordinate, and perform community-centered mental health projects, and to provide integrated and continuous service to people with mental health problems at the community level. So they engage in community-wide mental health welfare projects. They engage in prevention efforts. They provide public education and management of community resources, conduct research, and do suicide prevention. And they also have 24-hour mental health crisis telephone counseling. So this mental health welfare center is for people of any age, but for older adults specifically, we have this center called Integrated Support Center for Older Adults Living Alone, and this center provides emotional support services for older adults who are living alone. So they provide individual counseling, mental health medical care support, group activities, and community resource linkage support. And by providing these various customized services according to the needs of the clients, the risk of social isolation, suicide, and solitary death they aim to reduce the risk of these important issues. So one of the key service at this center is what is called Banerjee in Korean, this companion to talk with, if we translate in English. And basically it's a friendly visit to ensure safety and well-being of older adults living alone. And there's a support service by phone. During the pandemic, because of the COVID-19, the friendly visits has been suspended in many cases. So there has been a great challenge to this program, but people still provided services by phone, and they delivered meals and other materials to homes of older adults who are living alone. So what they do at the center for integrated service for older adults living alone, the center has many different programs. So the first is depression prevention program. So it provides stress management and depression prevention programs such as gardening and meditation. And it also provides social relations program, and it forms social relationship through group leisure activities, lifelong education activities, and supports fun and healthy leisure time. It also provides cognitive activity programs, such as art or coloring programs or small muscle use programs to help enhance cognitive abilities. And finally, it provides self-help group assistance. So it encourages the improvement of social relations by connecting users to self-help groups, social activities, lifelong education, and volunteer work. And finally, as for the dementia, Korean government has executed a series of dementia management plans over the past decade. So it first started in 2008 with the first comprehensive dementia management plan, and it was the first national plan to address the problem of dementia in Korea. And at the beginning, it was mostly medically oriented model, and it also focused on prevention. So it had the plan had a lot of measures of detecting dementia and providing assistance for people to prevent dementia and visit healthcare agencies when they find symptoms. Now we have fourth comprehensive dementia management plan, and before that, in 2017, the Korean government issued a national responsibility system for dementia, and these plans they have more community-focused measures, such as reducing the burden of dementia patients and their families by strengthening the responsibility of the state and society, and also by strengthening the ability of the communities to respond to the needs of dementia patients and their caregivers, and also to reduce stigma associated with dementia. So I'll just briefly introduce the details of this fourth dementia management plan, which is the most recent plan issued. And this plan includes measures to enhance dementia policy context based on the needs of affected individuals. Also, it has prevention measures across the life course and also developed the treatment guidelines by severity of dementia, and it improved the long-term care services for dementia patients. The fourth dementia management plan also includes measures to expand and systematize dementia-related infrastructure. So it includes measures to expand long-term care facilities and hospitals for dementia patients and develop cohort studies and integrated management of dementia-related research. And finally, the management plan tries to support persons with dementia's aging in place by linking community resources. And this is primarily done by dementia relief centers in each community. And the Dementia Relief Center also collects information so that it can build, it can build comprehensive information management system for persons with dementia. And this is the final slide. And the Dementia Relief Center, which is located in each community, it engages in prevention efforts through early detection of dementia and engagement in cognitive exercises, and provides case management and support services for people with dementia. And when the people with dementia are missing, they connect with police system, and they try to quickly find them, and they also engage in prevention efforts to prevent people from getting lost. And they provide support and education for families and caregivers, and they provide community education and engagement program. Okay, so that's all I prepared. Thank you for your attention. And if you have any questions or comments, please ask questions now, or please contact me at this email address. Thank you so much.
Thank you, Professor Ha. We actually saw your daughter in your background. It was really cute, by the way. Thank you very much. So, thank you for giving us an in-depth overview of mental health issues of older Koreans and policy responses. It was very helpful. I'm sure the audience actually learned a lot as well. So we could take some questions, but given that we have only the last presenter left, we can probably just go ahead and learn from the last presenter, and then we can have a questions and answer session at the end of the presentation. So with that, let's move on to the third and the last presentation. So last presenter is Dr. Sunwoo Lee. Her presentation title is Psychological Well-Being in Older Adults During the COVID-19 Pandemic and Beyond. Dr. Sunwoo Lee is a Senior Research Associate in the Active Lifestyle Institute and a faculty of physical culture at Palacký University, Olomouc in Czech Republic. So let's welcome our last and the third presenter, Dr. Sunwoo Lee. Dr. Lee?
Yes. Yes. Thank you, Dr. Kim, for your kind introduction. I'll be keeping my camera off during sharing my screen to keep the quality of connection. But I will be coming back with it after my talk. So good afternoon, everybody. Do you think you are watching my slide now or not?
Oh, we don't see your slides yet.
Actually, I did already, but for some reason it's gone. What about now?
Yeah, we can see it now.
Great. So good afternoon, everybody. I'm sending this warm greeting early morning in Czech Republic. First of all, I would like to appreciate ASEM Global Aging Center for organizing this forum and having me today. My name is Sunwoo Lee and currently working at Palacký University, Olomouc, Czech Republic. I'm a social gerontologist. I'm keen to understand how older adults develop their way of living and in what ways they pursue a good later life. It might be good to mention that my talk today is a bit far from any psychiatry or clinical setting research regarding so-called mental health. Rather, I would understand mental health in a more broadened sense, so that I would be labeling it psychological well-being. Hope this works for you as well. I cannot move my slide for some reason.
So are you
Okay, great.
Okay. Yeah, it is working.
Yep. Today, I would like to first discuss 3 studies in which I examine the different aspects of psychological well-being of older adults. And I will add 2 more studies specifically considering COVID-19 pandemic situation. And I will be finishing with some key thoughts based on my current and previous research. But please note that in the given material, I provided a comprehensive discussion about psychological well-being, including key references. But due to limited time allowed at the beginning, I decided to remove them from today's talk so that I can focus more on individual study. But again, now we may be able to come back to it after this talk if time allowed. So let's move to the first study. Social exclusion involves multiple disadvantages derived from various factors that are also highly intercorrelated. And why social exclusion matters? Because the social exclusion in later life appeared to be significantly and negatively affecting a wide range of health, well-being, and quality of life in older adults. And one of the approaches on social exclusion suggests 5 domains of social exclusion that are exclusion from material resources, civic activity, social relation, basic services, or neighborhood cohesion. Here, using European Social Survey data, I examined those 5 different forms of social exclusion in relation to older adults' happiness, life satisfaction, and health perception across different European countries. I found a significant difference in both measures of social exclusion and well-being index across different European countries that I categorized into 4 different groups. And one of the key findings is that older adults from Nordic countries showed lower level of social exclusion and higher levels of well-being. And in contrast, older adults from Central and Eastern part of European countries were more likely to score low for well-being and high for social exclusion. Following tables may include too much information each, so I would point out a couple of key or important findings only. So all 5 domains of social exclusion were significantly associated with 3 indicators of well-being. And this association was pronounced particularly in Central and Eastern part of European countries. And also, of the 5 different exclusion domains, exclusion from material resources and then exclusion from neighborhood cohesion were the most important aspect related to well-being of older adults across the European country. I would also point out that again, I have and I also would like to point out that the civic participation was a significant factor that predicted happiness in Western and Middle Eastern European countries. However, no significant association was found in Nordic and Southern European countries. And in Middle Eastern countries, in Middle Eastern European countries, social exclusion indicators were all significantly associated with perceived health. But in Nordic countries, only 2 exclusion, exclusion from material resources, which I used the household income, and the neighborhood cohesion predicted general health. So all these findings reinforce the inequality in well-being linked to social exclusion across different European society. So to promote psychological well-being of older adults, we need to tackle social exclusion in later life. And to do so, we need to develop better guidelines for the interventions at multiple levels, global, European, and national, maybe more specific community level strategy as well. The second study I brought up speaks about loneliness, and I know this topic will be discussed tomorrow, so I will try to keep it pretty short. A famous Harvard study of 75 years longitudinal observation concluded that a good relationship is the most influential factor of good later life. And we are well informed that a lack of social integration and sense of loneliness and chronic loneliness are harmful and negatively affecting physical and mental health and social well-being among older adults. And risk factors for loneliness include female gender and poor health status, and not married, being widows, and low social economic status, and lack of social network or lack of social activities, and depression. Since I have settled down in Czech Republic, I was wondering if what we know about loneliness was applicable to the national specific aging population. So expecting that I would retrieve such information, otherwise find any gap in literature, I used a sample of Czech older adults from shared database and examined how Czech older adults experience loneliness. And this study reinforced its significant association with the demographic, health, social, psychological variables, and that are well corresponding to existing literature. Yet some findings contradicted universal assumptions regarding loneliness. For example, there have been greater studies that being a woman and old age are more likely to experience elevated loneliness. But there was no significant gender difference found in the Czech sample data, and relatively younger groups were more likely to score high on loneliness. And also, I was expecting that Czech older adults would demonstrate higher level of frequent loneliness because the highest proportions of loneliness often observed in Central and Eastern part of European countries. But only 5% of Czech sample reported they often felt loneliness, which is quite similar to or even lower than European average of 5% or 7% of frequent loneliness. And this study of loneliness aimed at Czech older adults may suggest that to improve our understanding of loneliness over older adults, we should more carefully incorporate social culture and maybe even historical background of the society that might reshape or inform the meaning of loneliness of the older generation in a society. Next study is about passive suicidal ideation among older European adults. I may have to start giving you a quick background for the study. As you see here, suicide rate of the older adult ages 65 plus is significantly higher than average of the general population. And a higher rate of suicide among older adults exists in many societies regardless of how much advanced the country is or across different welfare regimes in Europe. Males, older age, or poor health condition, disability, or social isolation, and trajectory of alcohol, drug use, and psychological instability like depression, anxiety, are considered as key risk factors for suicide. And also importantly, desire for death or suicidal ideation is a critical antecedent or warning sign for the suicide attempt. So in this study, I provide an overview of potential risk factors for passive suicidal ideation aimed at European older adults. passive suicidal ideation was at its highest level among older adults from countries named France, Belgium, Spain, Poland, and Germany, which is above the average of 6%. There was a high gender variation within and across the countries. We have been informed that actual suicidal rate is universally higher among males, but in relation to passive suicidal ideation, females accounted for considerably more than to older men. This not corresponding prevalence rate of suicide and passive suicidal ideation between men and women may suggest that we are not supposed to consider those older adults who express suicidal ideation as a potential suicide. In particular, in females, maybe instead we use this index as an important indication of considering seeking help or of actually seeking help. And over the gender difference, highest prevalence of suicidal ideation was found both in married couple and widows. And study sample also show that compared to other age categories, older adults aged between 65 and 74 years, which is relatively young old, also those older adults living in a rural area were more likely to demonstrate passive suicidal ideation. Passive suicidal ideation has numerous correlates. First, passive suicidal ideation is greatly associated with poor health or disability that would hinder older adults' independent living, which in turn increase negative thoughts like hopelessness, helplessness, and at the end, suicidal ideation. I also would like to highlight depression pathway to suicidal ideation, that depression may play a significant role as a pre-symptom of suicidal thoughts and behavior. And interestingly as well, different social roles were associated with passive suicidal ideation, but not in the same way. For example, number of children decreased the probability of a passive suicidal ideation, but number of grandchildren increased it. So older adults may have different social expectation and different experience derived from different social roles they are to adapt with age. So we need more contextual understanding of those factors independently, but also together influencing older adults' passive suicidal ideation. Furthermore, suicide attempt. Up to this point, I presented 3 of my studies that investigating different indicators of psychological well-being of older adults in Europe. I would round up by noting that there are factors persistently affecting psychological well-being, such as poor health and low socioeconomic status. But psychological well-being is multi-dynamic and involving high variability. So that is incorporating complexity of demographic, economic, and environmental, social culture, and even behavioral aspect of psychological well-being remains a challenge. But I would take it as an opportunity to answer what explains such a variation and to better understand how older adults are able to strive for their well-being in a given situation. Now I would like to bring your attention to more recent years of pandemic. Not surprisingly, a high volume of studies informed about negative effect of pandemic crisis on older adults. Likewise, in the European context, using shared COVID-19 survey data, research has evidenced for the significantly increased psychological distress and the mental health problem in European older adults. Here, what I noticed was that relatively little studies focused on any material or financial adversities the older adults might also experience during the pandemic and its impact on their psychological well-being. And I was interested in seeking potential intervention strategy. The European Foundation for the Improvement of Living and Working Conditions, so-called Eurofound, and this is one of the European Union associated agency. Eurofound developed online survey to investigate European psychological and behavioral responses to the COVID-19 pandemic. According to Eurofound survey data collected first in April 2020, 1 in 3 European older adults aged 65 plus reported a worsened financial situation since the pandemic outbreak. And about 20% of older adults reported difficulties paying for their basic necessity. And such a worsened financial situation was reported more in female and relatively young older adults and those with higher education and even in retired. And as expected, finance change during the pandemic crisis was significantly negatively associated with subjective and psychological mental well-being of older adults. Building on this, I completed 2 studies. First, exploring the role of institutional trust, and the second, exploring the role of psychological resources in the association between the adversities and psychological well-being. So institutional trust reflects a person's confidence in or satisfaction with or attitude toward state or non-state organization. And studies show that high level of public trust facilitates implementation of restriction and perceived sociality and preventive and help-seeking behavior. And in a society with a higher level of institutional trust, a lower COVID-19 death rate was found. So here I examined if older adults trust in institutions, including news media, the police, their national government, and European Union and national healthcare system affected their psychological well-being and mental health. Analysis revealed that institutional trust positively contributed to perceived well-being, and its moderating effect was statistically significant, which means institutional trust potentially mitigated the negative association between material adversities and well-being of the older adults. And this moderating effect was pronounced in the association between adversities and psychological distress. Additionally, I also found when you consider the effect of individual institutions, the role of national government and healthcare system could be highlighted. What we have observed is that according to Eurofound, financial inequality has increased during the pandemic. But institutional trust, as I indicated, one of the potential resources to maintain psychological well-being of older adults appeared to decrease over the course of the pandemic. So we may have to reconsider the role of institution in the ongoing pandemic and also look for a way how to better promote it, considering the extensive years of pandemic in preparation for the onset of another global crisis. So institutional trust represents more structural level resources than what are more personal level resources to manage COVID-19 related adversities. We have been talking about a lot negative effect of pandemic on increased adversities in aging population. But interestingly as well, some studies show that older adults tended to be more resilient and tolerant with larger restrictions during the pandemic. For example, a study indicated no significant difference in COVID-19 related stressor between older and younger adults, and that older adults even reported a higher level of coping efficacy than their younger counterparts. And study also examined the perceived coping level of American older adults ages 70 years old or plus, and during the early weeks of lockdown. And this study showed that nearly 90% of study sample reported they were practicing positive coping strategy, like engaging more activity, seeking available social support, and maintaining optimistic outlook. And studies also show that a higher level of optimism that was measured before the pandemic was significantly related to better mental health and better emotional well-being that was follow-up assessed during the pandemic crisis. And optimism significantly contributed to experiencing positive emotions. So building on this, I examined how resilience and optimism affected mental and emotional well-being of European older adults using structured education modeling. Here I only present a final study model, including significant paths between the study variables. What this model suggests is that older adults who score higher for resilience and optimism tended to report greater life satisfaction and happiness, better health perception, and higher levels of mental health and lower psychological distress when controlled for potentially negative effect of pandemic adversities on well-being. And also importantly, well-being index like mental health, life satisfaction, happiness, and psychological distress tended to change over time, like up and down, up and down. But measures of resilience and optimism were relatively stable between different measurement points during the course of the pandemic. And this allows me to argue that resilience and optimism can serve as a sustainable or non-material coping tool in later life changes or challenges. Therefore, we should better promote them. Now, I would like to conclude this presentation with some remarks. So, based on all my previous works before and during the pandemic years, in an effort to better study or better understand psychological well-being of older adults, there are a few considerations I would like to lay out today. First, it is important to acknowledge that in recent decades, scholarly discourse on aging has moved from the old age as isolated concept to aging as a lifelong process. And this shift of perspective requires to adapt a life course approach, and thus data from more longitudinal observation would be helpful to identify what are the key makings of psychological well-being in later life. And also importantly, we are to better promote and empower awareness of the potentially positive aspect of an aging society. I may have to acknowledge that those earlier studies I presented today were all about negative aspects in later life, like the social exclusion, loneliness, suicidal ideation, with an emphasis on problem that should be addressed first. But finding during the pandemic outbreak regarding how older adults deal with pandemic adversities may provide a novel insight into how we frame or portray aging population. So we have to work on the one hand, physical and cognitive declines in aging process, and so increased dependency of older people. But on the other hand, older adults' inner capacity or potential for development and potential to contribute to their own well-being and that of others. Aging populations become more diverse with increasing tendency of living independently. So I believe an equal importance has to be attributed to the promotion of older adults' readiness and preparation that can facilitate positive, active, or thriving aging, as we call it. And in time, the aging research should incorporate more diverse disciplines, I believe, such as positive psychology, humanitic psychology, and developmental psychology. So by doing so, we can improve our understanding of why and how some older adults can succeed in later life challenges. So I thank ASEM Global Aging Center for allowing me to share my work today. I'm very excited to be here with distinguished experts who are making their effort to improve older people's life through their practices and cultural initiative. And I'm very looking forward to hearing from you all what you think and what you suggest. I thank you for your attention.
Thank you, Dr. Lee. Thank you so much for sharing your research on mental health issues of older adults, and also sharing and present findings from the share data that you used. We learned a lot from your research among European older adults. That was really interesting and helpful. So now we all three of the presenters presented their discussions on mental health issues of older adults and human rights. So now we received a couple of questions for each presenter. So I will read some questions and you answer those specific questions, and then we might have some general questions if we have some time. So that's how I'm gonna actually use the remaining Q&A session. So hopefully that works for you all. So. Yes. Dr. Banerjee, are you there, or did you already leave? Have you already left? So I think Dr. Banerjee left. And Professor Ha, are you there? Okay, well, yes.
I'm here.
Yes, okay, so Professor Ha is here. So Professor Ha, I have 3 questions for you from the audience. So I will read those questions for you. And while you are actually just preparing for the, answers, and I will read also the questions for Dr. Lee, and then we'll actually listen to your answers. So, so questions for Professor Ha. So the first question is that although the Korean government has developed various mental health care plans to enhance mental health across the life course, depression and suicide rates for older Korean people remain higher than those among other OECD countries, you already mentioned. It seems that available mental health treatments and policies are not always effective in ameliorating suicidal symptoms among older people. So what are the challenges of current emotional support services for older people, and what strategies should be changed and provided at the individual, community, and the government levels? In particular, how can a human rights approach be applied to the current emotional support systems in Korea? So that's the first question. And we have the second question for Professor Ha. So symptoms of depression are most common among older age groups and people with lower levels of education. Higher education indicates a strong social background that enables active engagement, which leads to better mental emotional health than those with disadvantages social backgrounds. Furthermore, people with higher socioeconomic status may have more social resources, enabling better social networking. In addition, disparities in mental health service use among older people by socioeconomic status is well documented. So our question is, how can socially disadvantaged older people make better use of mental health services, and what practices should be adopted for these disadvantaged groups? So that is the second question. And the third question is very similar, relating to educational level. So in your talk, you mentioned the educational level and the depressive symptoms, the relation between those two, and why would people with lower levels of education be more depressed? Can educational level be a statistically significant variable for general mental health in old age? So that is for Professor Ha. That was the third question. So just while you are actually just structuring how to answer those, I also have some questions for Dr. Lee. So I will also read two questions for Dr. Lee, and then we'll actually move to the answered session. So the first question for Dr. Sunwoo Lee is, based on the research you introduced, I found it interesting that there is variability within European countries in terms of older people's mental and emotional health. You mentioned cultural, peculiarities, socio-economic and health differences, and macro level differences, but these factors are not centered as a variable in the study, but are instead inferred as possible factors. At the macro level, what could be the most significant institutional, regional, or cultural level factors that influence older individuals' mental health and well-being? Also, when compared to Asian countries, how do these macro level factors appear to differ when it comes to older people's mental, emotional health? So this might give important implications for the virtual role of macro level factors that can influence older individuals' mental health and our ability to develop preventive strategies for them. So that's the first question. And we have also the second question for Dr. Lee. So you mentioned the important role of resilience and optimism during the COVID-19 in the relationship between stressful periods and perceived well-being. This may require individual level interventions such as cognitive skills and behaviors and biological factors, etc. So these, let me see. So this may require individual level interventions to increase the resilience and optimism, but in different environments, such as the COVID-19 pandemic. So I think local and the government's role could be even more important in this respect. So what kind of community efforts should be made to increase resilience or optimism among older adults? I also personally quite interested in this part of question as well. So those are questions we have at this moment. So while Dr. Lee is also, structuring your answer, so let's actually move to Professor Ha. So Professor Ha, what do you think about those questions, and also what is your answer?
Okay, thank you for the excellent questions. So just a second, let me. Okay, so first question was about effectiveness of policies, right? And the person who proposed question said that the Korean government developed various plans and measures to address depression and suicide, various plans to address mental health issues, but depression and suicide rates remain high, and it seems like the policies are not always effective. I agree to some part of that comments and not to all of the comments. I agree that these plans may not be effective in addressing all the problems that we have that are affecting mental health of older adults. For example, even though we have great mental health services, we cannot eradicate the poverty issues, which are really important for older people. And as you have seen, even during this very heavy rain, we saw that those who were living in an environment which are not adequate for health and even for going out, they are most disadvantaged to disasters. And older adults, similarly, when they have lower socioeconomic status, they might have many various problems that are prohibiting them from participating in society and working, and also having good food for nutrition. And those factors may all affect depressive symptoms or suicide rates. And also it can be related to access to health services. However, I don't think the policy measures are not effective at all. I think the welfare system is doing their best to address some of the important issues. So for example, what the welfare agencies are doing to promote the well-being of those older adults living alone is really, I think, applaudable. They're doing their very best to contact these people and see if they're doing well in times of difficulty. So I think we should keep doing that, and also make sure that we have strategies or plans to address other issues such as poverty and access to healthcare among older adults. The person asked, what are some of the strategies at the individual, community, and government level that are necessary to enhance mental health? I think, well, I've talked a little bit about it, but I think it all comes together. So at the individual level, I think each individual can do a better job of preventing mental health problems. So as I said, like nutrition is a very important issue, and checking on what are some of the factors that cause depressive symptoms or anxiety. Self-awareness is really important. And at the community level, we need to have a society where people can, as in the presentation of Dr. Banerjee, sorry, I can't pronounce well,
Banerjee.
but he talked about how it's important to care with consent, autonomy, and respect. Those are important. I think it's important in Korea as well. So we often think that we know everything about older adults and just do whatever we think is important for older adults, but we need to incorporate their voices in policy measures and think about how to give autonomy to them, as well as give respect to what they want to do in their life, and in making their life more dignified. And also at the government level, we just have to, I know the government is doing a lot, but we just need to pay more attention to most vulnerable populations within older adults and see what they need to improve their quality of life, to be able to participate more in the society and to enjoy healthy lives even toward very late life. human rights approach, I think is really important. When we look at Convention on Rights for Persons with Disability, we see that there are many rights are named in that convention. So, for example, right to health, right to education, right to gender equality, things like that. And those issues are I think, as important among older adults as in people with disabilities. So we need to ensure that every individual within the population of older adults are respected, and they have a chance to pursue quality of life in their own life. The second question was regarding socially disadvantaged older adults and how they can better use mental health services. And again, the poverty issue is such an important issue to tackle as we consider mental health of older adults, especially those with lower socioeconomic status. So how to ensure the basic condition of life is really important. And one of the issues that social welfare, one of the issues that workers in the field find very challenging is that some of these older adults, they are reluctant to getting the services, and it's hard to reach out to them. And I think in those cases, we really need to find out how can we, connect with them. Sometimes it's not just about, giving help to those who are in need, but also, sharing, sharing what they need and communicating with them. So I don't know. I don't have the correct answer to this, but I think we need to be more proactive in finding out what they need and try to listen to what they are saying in making the policies. In regard to that, I know a researcher who does a project called Traffic Light. It's called Traffic Light, but in fact, it's about asking older adults who come to Meals on Wheels types of services and asking them how they feel using the traffic lights. So green light means that they're fine, and yellow lights, they have some problem, and red lights means that they have more than 2 or 3 problems. And it includes problems regarding social contact or health or their loneliness. So we need to also develop measures to develop indicators to capture things with a very easily understandable measures. So I think that's important as well. I'm sorry, but I kind of didn't catch the third question. So would you mind repeating the third question?
No problem. It was related to the educational level. So the question was, how would people with lower levels of education be more depressed? Can educational level be a statistically significant variable for general mental health in older adults?
Okay, so I think, well, I haven't searched for research to provide the most correct answer, but I think lower education is related to other issues such as lower health, and lower physical health is related to higher depression. So that's one thing. And also lower education is related to a lower income and other living conditions. So that's another factor affecting depressive symptoms. Whether lower education itself affects depressive symptoms, I am not sure. I'll have to look for the studies relevant to that.
Thank you for the very helpful answers to the three questions. I'm sure the audience would really appreciate your answers. Thank you, Professor Ha.
Thank you.
And Dr. Lee, Dr. Sunwoo Lee.
Yes, I'm here.
Okay, so we had actually two questions for you. So whenever you are ready, you can probably answer.
Well, actually, I was listening to Dr. Ha's answer, so I hope I can organize in a certain way. But the first question is a really big questions, and it's not about that my answer is more about how I think it's more about the question, and it's more about how we all discuss together about this kind of potential factors that also link to psychological well-being of older adults. So how I start with the first question, I would like to I would like to bring the first presentation and also Dr. Ha's presentation. She also answered like some structure level or what is the macro level of factors like social economic status. For me, this is a really key element that to understand, better understand older adults' well-being and their way of living. And in that respect, I would like to bring also some intersectionality, the concept of intersectionality. So when we are talking about different level of factors or all the variability across and then within European countries, it's not simple to answer what affect most in aging population and positive psychology psychological well-being of older adults, because each country has a slightly different background and as a whole European Union, and you can see that there is some shared value and shared meaning and shared shared way of living that they would like to pursue together. But in the same time, there are so many different aspects going on across different countries, and we have different social norms. Even in one study, I categorized the 4 different European countries, like the Nordic, Western, and Central European and Southern. But even in this categorization of the country, you see a lot of cultural differences. So in Poland, in Czech Republic, you are expected in a different way when you get aged. And due to, because of that reason, we have different social expectation and different social experience. And definitely across the different country, we have different gender norm and gender values. So even female, when you are old as a woman, it's also different that you have a different social expectation from your family member and even in a community, in a society as well. But again, I would like to go back to this socio-economic status. That's the kind of key element that I don't want to say that, but it significantly determines older people's and health and quality of life and psychological well-being, I would say. And the good thing is, the bad news is, once it's fixed like that, as just like the lower education level, most of the time it leads to like a low social economic status in the middle ages and old ages. So I'm not a kind of policy maker, and I'm kind of less experienced in that respect. So I'm not sure how to intervene in this kind of important factor that influencing psychological well-being of older adults. And again, the healthcare system and how government deal with like a pension and then social services and then welfareism, all this kind of structural level factor, I think that significantly affect other psychological well-being and mental health. Of course, there are so many other form or factors like individual level or even meso level as a community level or psychological level. But if we are considering macro level, so we try to find a good way to intervene those factors that highlight socioeconomic status and then healthcare system in each different country, regardless of continental Europe or America and Asia, something like that. And I'm not sure that this is a really clear answer to the first question. So please, Dr. Kim, please just join me if you would like to add more insight from your side as well. If I just move to the second question regarding how we can better promote like resilience or this kind of optimism, it's more like psychological resources of older others from community level. This is also really big question. And when we are talking about some intervention, like we are talking about bottom up or top down strategy, and from policymakers and health authority, we are trying to make some top down intervention to improve mental health, psychological well-being of older adults. And what is the bottom up strategy that we also can intervene, like making more social psychological intervention or counseling program for older adults to make them feel more cared or treated in a better way. But I think personally, I believe that community level effort is the key or the best way to intervene to promote or to tackle any like disadvantages the older adults experience. And what would be the good practice for, regarding community level effort to promote resilience and optimism? It's many studies show that the personal level of, for me, psychological resources can be improved by like better social cohesion in neighborhood environment. And if you reduce some risk factor around the neighborhood, that can also increase the positive emotion and the positive experience in the place where you actually live on a daily basis. So it's a bit tricky question that how to improve the psychological well-being or resilience or optimism, this kind of psychological level resources among older adults. But the answer can be still in the vein of like the community or society level, and surely we have to improve some awareness or some attitude toward the aging population, so we can tackle down all this ageism or discrimination or some negative aspect, negative image of aging population. But these are again regarding the community level effort that we promote more like a positive, more facilities in a community or providing more community level care or bring those older people to community centers so they can have a better leisure experience or even volunteer activity among older adults can be really promoted to improve the self-efficacy of older adults, therefore promoting resilience and optimistic view in their later life. So that's just coming like popping up in my mind for now. Definitely maybe from my published paper or in the future paper I can better elaborate those answers. But for now, I would like to just stop or listen more opinion from your side, maybe. Yep.
Yeah, thank you, Dr. Lee, for your answers. The answers were really helpful, and the audience actually learned a lot, I'm sure, and including all of us here in the room and also joining us online. As you actually said, especially to like how to improve in terms of how to improve resilience and optimism, I think, there may not be the best answer to actually just to improve those. But as you also said, and also Professor Ha also mentioned, like all levels of effort should actually come together, like individual level and community level and government level efforts should actually all come together to improve psychological health of older adults. I think that's why we are here to discuss mental health and emotional health of older adults in different countries across all these world. So with that, I'm sure the audience have multiple questions, but we also have to actually give you some time to make some final remarks, I think. So before we close the session, I'm sure the wonderful panelists have something to say before they all go. So I'd like to ask all panelists, I'm sure Professor Ha and Dr. Lee is here, and also Dr. Banerjee, he's gone, right? So, okay. So I'd like to ask two panelists, Professor Ha and Dr. Lee, to make a few final remarks. So, Dr. Lee, do you like to go first this time?
Well, yes, I think I already did in my last slide, like as a remarks for my based on my research. But when we are talking about psychological well-being of older adults and the meaning, the semantic meaning of psychological well-being and how older adults pursue or strive for their psychological well-being in a many different ways. And so definitely we need some individual level approach, but from more like a policy making or more giving a service perspective, this can be approached in a way that how we promote like psychological well-being in a more positive way. And I reinforce this because and we are really working hard to tackle down all the problem or negative stuff in aging population. So, but it really frames aging population more like a fragile, vulnerable, or lacking capability. And I believe this kind of view or image of aging population should be confronted from like different viewpoint of some resilience or relevant psychological resources that older adults developed over their life course. So we can call maybe wisdom or spirituality and lifelong experience. So this is all like their asset. There is inner asset and inner capability that older adults can strive for their well-being. So again, I would like to emphasize that we have balanced the view on aging population, like working on what they cannot deal with much in a better way, but also promoting what they can do in a certain way in an aging society. So that would be my final remarks. Thanks.
Thank you so much. So, Professor Ha, your final remarks?
Thank you. I think as Dr. Kim, you said earlier that we need an integrated approach to mental health, including individual level, community level, and governmental level approach. I totally agree with you. in that we really have to have a concerted effort from various perspectives and various fields and also various levels. We need to, have common goals of promoting mental health, and we need to, collaborate to achieve that goal. Also, I think we need to take into consideration that mental health is not alone. So it's related to physical health and social well-being, and they're interconnected. So we cannot think about just mental health issues alone. So I haven't had a chance to address a lot of these issues, but Dr. Banerjee addressed those issues in his presentation. So ageism is a very important issue to address in Korea, especially during the pandemic. We have seen a lot of, prejudice or, older adults have been isolated more than other populations group in terms of, visitations, and a lot of healthcare centers or nursing homes were isolated even from family visits. So those issues need to be addressed, not only as COVID issues, but also as a mental health and social isolation issues. So those things are important. And also elder abuse is another important thing to address. Many older adults, they try to hide the problem because oftentimes it involves family members, but it's very much related to mental health of older adults. So, and it's a human rights issue too. So we need to think about how we can enhance the social well-being of older adults to prevent mental health problems of older adults. So those two go together, I think. So that's what I wanted to say. Thank you so much for the opportunity to talk in this conference.
Thank you so much, Professor Ha, for sharing your final remarks. That was very helpful. So our panelists actually shared their expert knowledge in their research and also sharing their the current issues of mental health issues in each country or cross-culturally. So thank you for attending. We do really appreciate your interest in this very important topic. Audience, you can ask further questions to the panelists via email. So let me close the session with thanking the wonderful, our distinguished panelists, and also the ASEM Global Aging Center. Thank you very much.
Thank you very much, Professor, for leading the session, and also the panelists for sharing your insights with us at the session number 1. We were able to examine the current status of the mental and emotional health issues and also discuss what the countermeasures can be and have been adopted. So with that, we're going to close the first session. And before we move on to the second session, we're going to take a break. We are to start the next session for Civil Society Talk Concert at 4:00 p.m. Korean Standard Time. So as we are to begin at 4 p.m. Korean Standard Time, please make sure that you will be here with us beforehand. Having said that, we'll see you all at 4. Thank you very much.